Well, welcome. This is the first event for Health is Primary in a major city, or any city actually. So thank you so much for coming this morning. We're going to have a very interesting time hearing about transformations in healthcare and primary care, in family medicine in particular, in our state. I'm going to be introducing, first of all, Glenn Stream, who is a family physician in Rancho Mirage, California, and the past president of the Academy of Family Medicine in this country. He serves as the chair of the board of Family Medicine for America's Health. Glenn is a Washington native, and we've had a chance to have a good friendship develop over the last several years working together. And he trained at the University of Washington and trained also at Swedish, which is a little-known institution up the hill that I happen to run the training program at now. We are privileged to have him here to give us, or to introduce our comments this morning. He also has a degree in biomedical informatics, which he's using now in his role down in California in his current position. Like many of us, the roots of our family medicine careers vary as far as where they come from, but Glenn did work in a small rural community initially after residency in Kashmir, Washington, so he's familiar with what it's like to be in a small town, and then moved to Spokane to work at the Rockwood Clinic in a much larger city. And then now, being at the perspective at the national level, he sees where family medicine is going. So please welcome Glenn Stream as he introduces his remarks.
Good morning, everyone, and let me add my welcome for all of you being here, and thank you for that introduction, Mike. In fact, Seattle is my hometown. I literally was born at Virginia Mason, which, as near as I could tell, knowing that you tell distance in Seattle by how many Starbucks are between, so I think there's literally maybe only one Starbucks between here and there, so it's very close. So welcome. I'm very excited to be here to kick off our tour of communities around the country, communities where primary care and family medicine are making health primary. Our campaign, Health is Primary, is working to collect and share stories of innovation that are driving the future of health in America. And you will hear just a sample of the incredible work being done here in the state of Washington from our speakers today. And for those of you not aware, Seattle and the Puget Sound area and Washington in general, very much innovators nationally in healthcare improvement and improving health of people. Two of our board members are here today. Mike Tuggy, who you just met, represents on our Family Medicine for America's Health board. Represents the Association of Family Medicine Residency Directors and is a clinical professor at the University of Washington and residency director at the Swedish Family Medicine Program. We also have Dr. Jen DeVoe. Jen, are you in the audience? Jen is at the Oregon Health and Sciences University, where she is an associate professor and represents on our board the North American Primary Care Research Group. So our group, Family Medicine for America's Health, has come together with one mission, and that's to improve the health in America. As everyone knows, our nation is facing a health crisis. We have the most expensive healthcare system in the world, yet we rank almost last in industrialized countries in the health of our people. It's time to put the health back in healthcare. We believe the solution to many, if not all, of our healthcare problems can be found in primary care. We're so convinced of it that we built the Health is Primary campaign to make the case to patients, policymakers, and payers that a strong primary care system will allow us to deliver on the triple aim, the idea of better health, better healthcare delivery, and reducing healthcare costs. Many of us also like to talk in our prep session this morning, we were talking about the quadruple aim, which is also to improve the professional satisfaction of physicians and other folks working in the healthcare system, knowing how stressful it can be. The evidence that primary care is strong, and it speaks for itself. We know that access to primary care can help us live longer, healthier lives. In areas of the country where there are more primary care doctors per population, death rates from cancer, heart disease, and stroke are lower, and people are less likely to be hospitalized. An increase of one primary care physician per 10,000 population can decrease costly and unnecessary care. Outpatient visits decline by 5%, inpatient admissions by 5.5%, ER visits by 10.9%, and even surgeries by 7.2%. Evidence shows that primary care is associated with a more equitable distribution of health in populations. U.S. adults who have a primary care physician have 33% lower health care costs. Medicare spending is lower in states that have more primary care physicians per capita, and they have more effective, higher quality health care. Health, quality, and cost. That's the triple aim that we must achieve in primary care is positioned to best deliver that. I'd like to share with you a video from our campaign.
When we were growing up, medicine meant our family doctor. When we were sick, had a broken bone, or got hurt, that's where we went. The technology was simpler then, but our doctors took care of us and helped us stay healthy. Things changed over time. We changed, and healthcare started to change too. Scientific advancements made medicines and treatment better, but the healthcare system got more complicated. We started spending a lot more money, but all that investment didn't make people healthier. Healthcare started to feel a little disjointed and impersonal. Now everybody is talking about reform and the system. It's gotten pretty loud, but nobody's really talking about health, good health. Isn't that really what we all want? Our country has the best doctors, the best hospitals, and the most innovative scientists. Shouldn't we be healthy? Somewhere we lost our way. We forgot what matters. We need to embrace the values that make people healthy, like a long-term relationship with a trusted doctor, someone who knows us, our family, and our risk factors, someone we can connect with when we need them, who uses the latest technology, someone who can help us stay healthy, and when we're sick, help us get the most from the healthcare system, someone who can see the big picture and the small one. That's what the best healthcare should be, a system based on primary care that can make our advanced medical system work for real people. We know how to get there, and going there now can give us a system that works for everyone and makes us healthy again. Now is the time. Together, let's make America a place where health is primary.
Thank you. So what does healthcare in America look like where health is primary? We believe it looks a lot like family medicine, and we want to work to ensure that whether your primary care provider is a family physician or not, that you live in a place where health is primary. A place where doctors and patients work together in true partnership. Patients have long-term relationships with their doctors and see and treat the whole person. Technology supports and strengthens the connection between doctors and patients. Everyone has access to a medical home where most, if not all, of their health care needs are met, and coordinated medical neighborhood that cares for those additional services when needed. Prevention and health promotion are as important as treating disease. Doctors work with community leaders to address individual and population health. Health disparities are reduced by increasing access to primary care, and financial incentives align with good care and better health outcomes. Today you'll hear from our panelists about their practices and their work to ensure a primary care workforce in Washington State and the whole WWAMI region. For anyone in the room not familiar with WWAMI, which is probably a small group, that's the Wyoming, Washington, Alaska, Montana, Idaho State Coalition. Their conversation today will focus on aspects of their work and innovations that are helping them drive results for patients and communities across Washington State. While these stories may seem different, there's a common theme. They all focus on delivering continuous, comprehensive, coordinated, and compassionate care, the model of primary care that we know can transform our healthcare system in America. Ensuring a strong foundation of primary care is what's going to make us healthy again. In addition to our work to spread the word about how primary care is delivering better care, better health at lower cost, we want to do the work necessary to take it to scale and accelerate the pace of reform. That's why, in lockstep with our Health is Primary campaign, we are working with our other primary care colleagues, payers, policymakers, and others to enhance and modernize the primary care system in this country. We will be forming multidisciplinary teams to expand access to the patient-centered medical home model, improve the use of technology in practice efficiency and patient care, recruit the best and brightest to primary care specialties, and shift to a comprehensive payment model that rewards value over volume. This won't happen overnight, and we can't do it alone. We are inviting our colleagues in healthcare, payers, employers, patients, and the broader medical community to join us in this cause. And we are collecting and sharing models of innovation that are going to help make America a place where health is primary. And that's what today's session is all about. I'm going to turn the microphone over to our moderator, someone who knows and seen firsthand the ironclad rule that primary care is the foundation of the healthcare systems around the world that deliver for patients improved health. T.R. Reid has become one of the nation's best-known reporters through his books and articles, his documentary films, his reporting for the Washington Post, and his commentaries on NPR's Morning Edition. T.R. Reid has written 9 books in English, 3 in Japanese, and translated 1 from Japanese, I'm assuming to English. Although you never know how many languages somebody knows. From 1 book from Japanese. He understands healthcare. His 2009 book, The Healing of America, A Survey of Healthcare Systems and Innovation Around the World, became a national bestseller. And his film, U.S. Healthcare, The Good News, highlighted stories, many of them from nearby where we are standing right now, about parts of our system that are working. And since that's what we're trying to do in Health is Primary, he's here to help us tell these stories about primary care and family medicine efforts that are delivering in Washington State. So I'd like to turn the microphone over to Tom so he can lead our discussion amongst our panelists about the exciting work to drive a culture of health here in Washington State. Please help me welcome Tom Reid.
Hi, everybody. Good morning. I just want to say I'm just delighted to be here. I'm so happy to be in Seattle. And really, I'm not supposed to say that. I'm from Denver. And I think by city ordinance, we're required to hate the Seahawks. That's a rule where I live. But actually, if you don't tell anybody back home, I just love coming to Seattle. You know, as I'm sure you know, if you just walk down the street, the community spirit, the vibrancy, the energy, the innovative spirit of this city is amazing, I think, to those of us who are occasional visitors. And of course, you can see it all across the country. Seattle has revolutionized things in America, ranging from computing to coffee. You know, you just innovate like crazy. And this is absolutely, I think, reflected in the architecture. I love the architecture of this city, this dramatic, daring skyline that continually adding beautiful new buildings. But I think the best thing of all, and I think it says a lot about the civic culture of this city, the most daring and most dramatic building of all is the public library. I just love that about Seattle. You hired Rem Koolhaas to do your library, and it's right across the street. It's fabulous. I always go there when I'm here. And of course, that same innovation we can find in medical treatment in the Seattle area. I think there must be something in the water or maybe in the coffee around Puget Sound that really leads to breakthroughs in providing high-quality medical care at reasonable cost. As Glenn said, we made a movie for PBS called U.S. Healthcare, The Good News. I thought it was kind of an ironic title. Is there good news? And as a matter of fact, there are communities around the country providing a very high quality of care at way below average cost. And when we did that, we went around the country and we went to 2 communities in Puget, on the Puget Sound area, both Seattle and Everett, because you all, the medical profession here, are leaders in providing care. So just as a patient, just as a person who goes to doctors, I just feel grateful to doctors and health policy experts in this area, because you are innovating for our whole country. On a personal basis, I'm just a reporter, I'm not an expert, but when I got interested in health policy, there were people right here who helped me. There were several. I'd like to mention Professor Doug Conrad at UW, who has really helped me a lot with health policy, and then Michael Slonim at Group Health just taught me a lot about how healthcare works in America. So I personally feel an obligation to Seattle. But if you'll just indulge me for a minute, I think Seattle also offers me a huge debt. Yeah, I think you're indebted to me, and I'll tell you why. I did a great favor for this community. This is about 20 years ago. Here's what happened. I was a correspondent in Tokyo, newspaper correspondent, and Major League Baseball went on strike. So there was a summer with no baseball for weeks. And the sports editor of the Washington Post was going crazy, right? He had a whole section to fill every day and no baseball to put in it. He's pulling his hair out, you know. And he called me in Tokyo and he said, "Don't you guys have baseball over there?" I said, yeah, they play baseball here. He said, "Write me some baseball stories. I need them." So here's what I did. I went down to Kobe and went to this team called the Hanshin Tigers and wrote a story about the best hitter in Japanese baseball. The guy was a fabulous hitter. And there were a few Americans playing, a few former major leaguers playing in Japan. And I said to them, "You think this guy could hit major league pitching?" And Bobby Valentine, who had been the coach of the Mets, said to me, he'll be the batting champion if only some American team were smart enough to sign him up. And I wrote that. I said, some American team ought to sign up Suzuki Ichiro Suzuki. And the Mariners did. He totally changed your team and your community, and that's all due to me, don't you think so? So I think you owe me, but more as a patient, as a consumer of medicine, I owe you and I owe what's going on in this region, because the things that are going on in developing primary care in this region are phenomenal and are leading the nation. And that's what we're going to talk about today, new ideas in primary care emanating from Seattle that will enhance primary care across the country if we can scale up correctly. And so we're going to hear from a really distinguished panel of experts in this field. And what I'd like to do now is just ask each of our panelists, we'll start with Tom, to introduce yourselves and tell us what you're doing.
Good morning. My name's Tom Norris. I chair the Department of Family Medicine at the University of Washington.
Morning. Devin Sawyer, Family Doc, Program Director of a residency program in Olympia, Washington for Providence.
Glenn Stream, I already had my turn.
Rich Kovar, Family Doc, and I'm the Medical Director of Country Doctor Community Health Centers here in Seattle.
I'm Russell Meyer. I'm a family physician. I grew up in Walla Walla and currently run a residency program that is located in 2 counties in eastern Washington, including a rural training track.
I'm Carol Heyman. I'm a family doctor. I'm a geriatrician. I'm also board certified in hospice and palliative medicine. Currently, I'm the medical director of Iora Health in downtown Seattle.
And I'm Erica Bliss. I'm a family physician, and I'm also the president and CEO of Q-Liance here in Washington, Direct Primary Care.
Thank you. Thanks, everybody. One of the things we want to look at today is this idea that seems so natural to me, I don't even think it should be an idea, and this is a concept called patient-centered care, which evidently is an important new idea in medicine. As a patient, I always thought it ought to be patient-centered care. But as a matter of fact, as we all know, medicine in the United States became insurance form-centered care or administrator-centered care. And there has now been a movement, and a lot of it coming from right here, to build new kinds of practices and new kinds of delivery methods that focus on the patient. And several people on our panel have been leaders in that, but I particularly want to call on Erica Bliss at Q-Liance to talk about this, and then Dr. Carol Heyman to talk about what do we mean by patient-centered care? What's the idea there?
Okay. Well, thank you so much for having me on this panel today. Q-Liance was established with the express purpose of reestablishing the sort of primacy of the doctor-patient relationship. We started back in 2007 with a single clinic here in downtown Seattle and have grown gradually over the last 7.5 years to 6 clinics in the Puget Sound area. And we currently serve about 35,000 patients, a large number of which are Medicaid and exchange patients, thanks to the Affordable Care Act, giving coverage to all those folks, and a partnership we have with one of the Medicaid managed care companies. But we also serve individuals. We serve folks from employers, such as Expedia and Comcast. We work with unions, including the Seattle firefighters and other similar organizations. So we kind of serve a broad swath of people in this community. The reason for establishing Q-Liance and what we did was that my cousin, our founder, Garrison Bliss, had become really sort of discouraged by the fee-for-service insurance payment-based system that drove him to have to see more and more patients. I know this is a very familiar tune to a lot of you. More and more patients with less and less value placed on the relationship with the patient and actually helping the patient. And so he split off and started a practice charging a flat monthly fee and not billing insurance and taking care of a smaller number of patients, but really, really doing an intensive job addressing their needs. About 7 or 8 years later, he said, you know, I think I have something here. This might actually be one of the keys to solving our healthcare system's ills. I'd like to see if we could do this at scale. And that's why we started the company, was to see if we could figure out a way to bring the price down even further and make this something that could be scaled across the country, with the goal of meeting the triple aim and also the quadruple aim of bringing the joy back to medicine and bringing the satisfaction back to medicine because of the ability to take care of our patients. So patient-centered care, I agree with you. It's sort of funny that it's some big idea. And I would also say that our system talks about it a lot and doesn't do it. We try really hard, but we're so rooted in our old habits that we slip back to a healthcare system-centric model of care. And we even struggle with that at Q-Liance. You know, we talk about our clinics. I just told you about our clinics, but really that's not the care model. The care model is about focusing first on addressing the needs of our patients in whatever way they need us to. And that's what we tell our physicians and our other staff is your job is to figure out what patients need and get it taken care of. Whether you do it, whether you find someone to help you do it, make it happen. And then we'll see what results. The patients really respond dramatically to this. And I've sat back many times and thought about it and said, why are we, here we are in healthcare and we deal with human beings all the time. And we supposedly understand a little bit about psychology and behavior and all of that. And yet we've built our system to work against natural human behaviors. And then when people don't do what we hoped they would do with our bad system, we blame them for it. They're bad patients, they're overutilizers, they're frequent flyers, all these terrible things we say about people, which I personally would not like said about me if I was needing help from the healthcare system and not really getting it. So we really, our patients say things to us like, wow, I can't believe how much time you took with me. I can't believe how well my provider listened to me, or, I can't believe the time and attention that your staff paid to getting things done. And this has been even more pronounced with the Medicaid population who have experienced oftentimes very disjointed care or very sort of disparaging care, made to feel like they're a burden on the system. And in our system, they come in and they're treated like everybody else and like a valued customer of our business and a valued member of our family, so to speak. And they respond beautifully. And what do you know? Their anxiety level goes down and they don't need so much care. And when you actually have time to sit down and sort out what's going on with people and organize their care, they need a whole lot less advanced care, which is what I call everything outside of primary care. It's really, and it's a great source of satisfaction to us as physicians to be able to solve people's problems. And so going back to the, natural human behavior, people don't want to be sick. People don't even want to get health care. They don't want what we have to offer, but they need it. And from the beginning of time, human society has always appointed somebody to be the healer in a community. Not that they wanted to have to be healed, but because people get sick in all kinds of different ways. So we start with that and say, if I was going to have to do something I didn't want to do, wouldn't I want it to be a pleasant, comforting experience? And so that's what we've really focused on as our primary foundation. Now we're, really focused on building out our systems to make it scalable and systematic and supporting people so that, you don't have to be brilliant, you don't have to be perfect, you can be just a good solid doc or a good solid staff member and the system makes you great. And so that patients walk away feeling like, wow, I know I have a trusted advisor who's going to take care of me and has my back. That's, I think, the core part of this is we need to focus on what human beings need, address that, and when they say we're not addressing it, actually listen to them and say, wow, how did I not meet your needs? Tell me. Let me figure out a better way to do that. So I'll pass it to my colleague, Carol.
Thank you, Erica. And thank you all for having us here today. It's been a great pleasure getting to know this panel and getting to be here with all of you. A lot of friendly, shiny faces. You guys look great. I'll just tell you a little bit about my practice, just so you kind of know the model that I'm coming from. So I started my job back last summer, so I'm in a new position as the medical director of a new clinic that opened in October in the Central District with Iora. And our clinic is specifically serving seniors, Medicare patients over 65, so we have an all Medicare patient panel. I came to this position after 10 years at Swedish in the family medicine residency, and I was also the director of the geriatric fellowship. And I decided to take this new turn in my career because of a couple of gaps that I saw that were needed, that I wanted to work on filling, that I saw in my previous job. And one was that my residents and my fellows who were graduating well-trained and well-prepared to do really good family medicine and really good geriatric medicine, really taking good care of older adults, doing really good care at end of life, taking care of the stuff we can't fix, like dementia, figuring out how to try to make care simple and less complicated. We're then going into jobs and calling me and saying, I'm frustrated. I'm frustrated because the way of being a doctor that I want to be, the way of providing care that I know is right, I can't get a job where I can do that to the level that I would like. And so I sort of thought, maybe my next job should be trying to make clinics where the great people that I trained can have jobs that are super satisfying to them, where they can provide that really good care to patients. Especially with our aging population, we desperately need doctors who are happy and able to provide really good, solid, comprehensive care to our patients. The concept of patient-centered care, I agree, is, it's a little bit overused as a phrase, but in our practice, we sort of think of it as a culture of service. So we've read and borrowed a lot of things from the service industry around really thinking of deep, abiding service to our patients, who are our clients and customers. And that really does sort of bring the patient back to the center of the interaction. We also call it restoring humanity to healthcare, which I think sounds a little grandiose, but actually is an attempt to recognize that healthcare has gotten, like the video showed, extremely complicated, but really at its core should be a little bit simpler. My patients are older, they're complicated, medically complex, they have a lot of issues, and we believe that the best way to take care of patients in a patient-centered way is to actually figure out who they are. And that's not easy, They're not a list of problems, they're not a list of medicines. They're individual human beings, and they're complicated. So you can't really do that without giving them time, without giving them your energy and emotional attention, without giving them, the love that they feel from us. Part of how we've done that is that we've really built a healthcare team that can take care of them. Because I think one of the mistakes we make in medicine is we think the relationship is only between the doctor and the patient. And that's a sacred relationship, and it's wonderful. But the doctor's not the only person on the team that can have that relationship with the patient. In fact, sometimes the doctor's not the best person to have a relationship to work on some of the things that the patient really needs. So in my clinic, I have a really strong team that includes nurses, social workers, and a bunch of people that we call health coaches, who really act as allies to the patient to help them sort of lead their best lives. Because sometimes the patient, if you're really being patient-centered, what they need is not medical care. They need somebody to sit with them and figure out how to fill out their Medicaid application. That's really what they need. That's really patient-centered. Sometimes they need things that are not face-to-face visits, right? Which is the only thing you can bill for instance, in a fee-for-service world. But if you're working outside of the fee-for-service model, you can start to think about what your patient really needs, and you can be creative about it. So I had a patient who was living in an adult family home, group home out on the east side, demented, needed to come and establish care with me. Kids were really worried about her, a lot of common concerns of that patient population. And when it came time for the visit, the transport to transport the patient didn't come, and so the problem was the patient couldn't get to me. So the daughter called me frantic. We're going to miss our appointment. We really need to do this, super important. I said, well, actually, I don't need to see your mom. Why don't you just come? So then the daughter and the son came, because really what we needed to talk about was the care plan for their mother, who wasn't actually going to participate all that much in the discussion anyway. So really what was patient-centered for that patient was to let her stay comfortable in her home, and I went and saw her at the house the next week, but really I needed to have the discussion with the children. And that was patient-centered in that case. We had another case of a 96-year-old who had been in the hospital and then in the nursing home, then back in the hospital, then back in the nursing home. And we were trying to work on coordinating his care and helping his care team understand his care needs. I actually looked in the chart to see, and I saw that our team had 12 contacts with this patient's team, his family, his hospital team, his nursing home staff. Never saw the patient in all of those 12 touches. But that was what needed to happen to help make his care right. So that was patient-centered in a sort of a more creative way. So I've really enjoyed the opportunity to be creative about care. That's brought me tremendous satisfaction as a doctor, and I've also enjoyed the tremendous satisfaction that my team has felt in really being able to sit with people, know them deeply as individuals, and figure out how to help them. It's good fun.
Thank you. I just want to mention, I know I'm delighted to see we have a standing room crowd, but there are a couple of seats up front. If you want to come up here, it'd be fine. Could I ask you about the names? Erica, your practice is called Qliance. Does this mean anything?
Well, it purposely doesn't mean anything to start out. But it was, the name came about thinking about the kind of feelings we wanted to evoke in people when they heard it. That sort of subconscious thing of you hear a word and it makes you feel a certain way. And the things we were really focused on were things like quality, reliance, alliance, those kinds of things, and mashed those things together and came up with the name. But the ultimate purpose of the name is to create, they talk about it as, having an empty vessel and you fill it with meaning. And that's really what we've been trying to do as a company.
I really like that. And how about IORA? Carol's practice is IORA. IORA, what is it?
It's not an acronym, that's the first thing.
All right.
An Iora is a small yellow Sri Lankan bird.
Oh, yeah, I knew that.
Our founding physician, Rishika Fernandapule, who is himself of Sri Lankan descent, had a previous practice where he'd worked out a lot of the systems that became embodied in Iora, and that practice was called Renaissance Healthcare, and he said nobody could spell it. So he said, the next time I form a company, it's going to have a short name.
Okay, yeah. We all knew that. It was a Sri Lankan bird, right? Yeah, I kind of thought. I have to say, again, as a patient, that was so comforting and refreshing to hear these two doctors. They talked about making medical care a pleasant, comforting experience. And of course, as we all know, it isn't always that. It's nice that a doctor thinks about that. Restoring humanity to medical care, that was really a reassuring thing for me to hear. One of the things I noticed is both of these doctors talked about our practice and our patients. And this reflects another innovation coming out of this region, which is this idea that medical practice is not just some doc with a stethoscope and a patient, it's a team operation. And the Puget Sound area, Seattle, has been really a leader in emphasizing this aspect of medicine as a team operation, and Dr. Devin Sawyer and Dr. Russ Meyer are both leaders in this field. So let's ask them about team-based medical care. Devin, could you start?
Happy to, unless Russ really wants to. Oh, okay. Thank you again for having us. I'm really thrilled to be here. So my story to team-based care begins as a resident in the mid-90s in the same program, the same clinic that I currently manage as the program director. Graduated right from residency, stayed in the same building, the same place, same patients, became core faculty, and early on had this awful sense of doom that something wasn't right, something's not working. Really enjoyed acute care. The system's really set up to take care of patients when they have symptoms, but I was missing something with my patients that didn't have symptoms, particularly with our chronic care patients with diabetes. And it was this awful feeling like I was letting them down that sort of started us as a clinic on this journey of really integrating self-management, amplifying the role of other members of the healthcare team that were there, particularly the medical assistant, who's historically good at blood pressures and rooming patients, and really trying to figure out how to augment the relationship the patient had with our core team, with the medical assistant. And that was where the sort of journey began. Fairly early on, had an interest in getting patients together, so I had a few group visits, which were really chaotic, large, half-day, 25-patient events where the whole place had to shut down to accommodate this crazy thing. None of the staff liked them, none of the docs liked them, the residents hated them. And retrospectively, there was only a relatively small number of patients that kind of enjoyed them, and most sort of like, maybe one day, but not today. So through experimentation, through patients and partnering with the team staff, came to a point where we had two sort of epiphany moments. And these were very vivid memories I have a number of years ago. One was caring for a patient with depression, really struggling to figure out how to connect with this patient and have meaningful connections between these visits that were sometimes 3 or 4 months apart, and feeling like I was missing part of the story. Well, I was also her primary care doc and doing everything else, and she became a diabetic through the course of the first 5 years that I knew her. And I had this really awful, guilty feeling of relief that she was a diabetic. And sort of why I felt relief was because of this project we'd been working on to create a diabetes center of excellence within our clinic. So now I could plug her in with the medical assistant. Sherry could get to know her, who's the medical assistant I work with. And over the next year, I saw her depression get dramatically better, not because she was diabetic, but because she had a different relationship with our clinic. She had different types of visits that she was able to have. There was far more contact, far more focus on self-management, action planning, and she became a member of one of these mini group visits. And she met 2 other patients with diabetes that were also had sort of periods of depression. And she turned her life around because she became diabetic. The second story is a very similar story of a patient who I was working with through a number of years, seeing her once or twice a year on health maintenance, overweight, sedentary, hard to sort of motivate, sustained lifestyle changes, periods of weight loss, then weight gain. And she was pre-diabetic for a number of years, and then she became diabetic. And I had, again, that similar feeling of relief that she's finally diabetic, because now I can actually help her, and I could plug her into our system so that Sherry and the social worker and the pharmacist and the group visits, and I could get her into one of these little triads of mini group visits, and the same thing happened. She was able to sustain weight loss. Her A1C got better very quickly. She actually technically became non-diabetic, or sort of non-insulin diabetic, but her A1C was normal, but she was plugged in and had relationship with other patients of mine that really played a far greater role in the care that she received than she was getting from me or anybody else on our team. So it was those 2 aha moments that I realized that, yes, the acute care model that we've tried to force on chronic disease and prevention is not working. And we have to sort of reformulate an approach that's team-based and integrates the patient into the healthcare team very, very deliberately. And it has to be planned and thoughtful. It has to have a lot more contact with patients and involving them asynchronously and in person. So that's sort of my story. Russ? Your turn.
Great. So to keep it a little interactive, when I heard Carol say that visiting her patient on the east side, how many of you live east of the crest of the Cascades? That's what I think of when I think of east side. Sorry. The other side of the lake, yeah. The second thing I was thinking about as folks have been talking is, you all know the story about the 4 blind people and the elephant. And the wonderful thing is you guys are all getting to see what this fabulous elephant looks like as you hear all these parts. And our health system and the way we've dealt with it is pretty innovative in many ways, I think, in our region. So in 2007, we hired a behavioral scientist. Family medicine residencies must have a person to help you with the psychological aspects of care. This was a guy who kind of bounced around in his career because he didn't fit in the traditional system of seeing patients for 45 minutes in another building that were referred to him, and had the guts to step out and work on developing another model with many other folks in this country of integrated behavioral health. And I'm not calling it integrated mental health, although this is a psychologist, but integrated behavioral health. And we went along swimmingly well for about 6 years with a 0.75 person. And in 2014, the Washington State Legislature changed the law. And that law allowed us to have a patient see me in the same day as the behavioral health consultant, and both of us could bill, which meant that rather than scrimping along and trying to cobble together the resources, we finally had the resources to provide care to these patients. Within the past year, we've gone from a 0.75 provider to 6 providers, 4 at our site in Yakima, 1 at our pediatric clinic, and 1 in our rural clinic. At the same time, we've added in community health workers and care managers. And it's hard to pin it down to one thing, but if you look at that combination of services, we've looked at our inpatient service, which had been steadily growing over the years as our clinic visits grew and grew and grew. So the sort of old model, come see a doctor in the clinic, go to the hospital. With these new model things, we've had a 10% drop in our inpatient census. Now, can I track it back to the care manager or the behavioral health consultant? It's hard. But time-wise, I can definitely track it back to all of those changes. So that's sort of a macroscopic view of the team. And I thought I'd share a brief vignette of a microscopic view of that team. So last Monday, in our electronic portal, so patients can electronically message into the providers, a note came in, not directed to a provider, not directed to a nurse, but directed to the behavioral health consultant, all nurses, front office staff, back office staff, and the pharmacy, as well as the provider. And briefly, I have a provider in that clinic who provides Suboxone therapy. So this is folks who are addicted to opiates and can get them into an outpatient ambulatory type treatment. So when I came to your clinic, I was a mess. My 2 sons no longer talked to me. My grandkids, my 2 daughter-in-laws were told not to have anything to do with me. I spent my first Christmas alone. The worst, I think, was Mother's Day when my phone didn't ring. Then my birthday and the remaining holidays that I would have to sit out. Before I came through the doors of community health and meeting you all, I seriously pondered suicide. Thank God I found you all. Addiction was close to claiming my life. Thanks to you for helping me clear a path, and now my path in life shows promise. Today, I am a better mom, wife, and grandma. So as we talk about these macroscopic numbers and improvements, I think it is important, and I think we as family physicians keep this at our heart, is there's a patient that our team is caring for.
Questions. Devin, you talked about so modest. I mean, the doctor is treating the diabetes patient, and he says it's the other patients who really helped her. I really like that. Do you think that kind of group treatment would work for other diseases other than diabetes?
Yeah, absolutely, yeah.
Yeah. What have you seen?
We've had some success with smoking cessation mini group visits. And we've recently developed a polypharmacy group visit model, shared medical appointment model, with 3 or 4 patients in combination with a pharmacist. And it's all about medication reconciliation and focus on the medications.
What's medication reconciliation? You all know this probably.
So 1 patient, 4 specialists and subspecialists, hospitalization, And then they come back to their PCP and nobody knows what medications they're on. And so it's just an effort to transition those patients so that they have one medication list that's reliable and accurate. And it works really well to do that in a group format.
Are there other practices having groups of patients work with each other?
We're doing something with pregnancy. Moms help other moms with being pregnant.
I've been there. Yeah, it's okay, she can say. Russ, you said behavioral care health is not mental health. I thought it was.
So there's a stigma in our society with mental health. And so you're right. You are a journalist. You're going to cut to the truth. Thanks, TR. But I think it's important to recognize that our health is impacted in many ways. And clearly, mental illness impacts our life. And as all of us at this table who are family physicians and many of you in the audience know, we are that primary contact point. And so being able to pull a psychologist into the room nearly instantaneously to help with someone who's in acute crisis or has severe anxiety or depression is very helpful. And that has an impact on healthcare, but I think it's important to look at the broader behavioral aspects of health. If our health outcomes are dramatically impacted by smoking, drinking, diet, and changing those habits, the patients that Devin's talking about with their diabetes, these aren't medications that make those patients' lives better. They're behavioral changes that really make their lives better.
Yeah, that's really striking. We heard Dr. Stream earlier point out that other countries like us, advanced free market democracies, have better health outcomes, better population-wide health statistics, which is kind of striking if you think about it, because the United States, we definitely have the best medical schools in the world. We have the best trained doctors. We have fabulous facilities in our hospitals. Some people in America clearly get the finest care in the world and the finest facilities. The problem is there's a disparity in the delivery of health care. There are populations that are just not getting the kind of care that American medicine could provide, and Dr. Richard Kovar has been a leader in trying to offset these health disparities. Can you talk to us about it?
Well, I'm in that dreaded position of following up these heavy hitters in family medicine, but I'm very grateful to be invited to be on this panel, and I'd like to at least feel like I'm the voice, a voice speaking for the safety net, and that's a large safety net in this country that I'm very, very proud of, and I've committed my career to that. I've worked my entire life in the safety net. I've worked with the Indian Health Service and in Indian reservations. I've worked in migrant farm worker clinics. I've worked overseas in Africa and Asia and refugee camps and all that stuff, and I ultimately settled in a community health center in this country, and I've spent my career here providing comprehensive primary care services for vulnerable populations. I truly believe that health disparities are at the heart of every family physician in this country. It is what we do. It is what we went into this for. But I also happen to work in a healthcare system that is systematically designed to address those health disparities. It's a curious term, health disparities. It's loaded, and we all intuitively know how loaded it is. And everyone's got a different definition for it. For some, it's racial and ethnic disparities. Others, it's sexual orientation. It's poverty. It's rural versus urban. There are many, many ways of cutting that pie. But I think the most important thing is I work in a system that I don't decide. So when you want to talk about modesty, I'm pretty modest about this because I don't work for myself. I don't decide what those health disparities are. I work for a system of care that's designed to have a patient board of directors, a patient majority board of directors that decides what those disparities are and holds our system of care accountable for that. I work in a health center system that's moderate sized here in the central urban core of Seattle. We take care of 20-some-odd thousand patients providing comprehensive primary care services. But I also know that I'm a servant in a larger system of care that in this state happens to be about 350 providers, the overwhelming majority of whom are family physicians, in 220 sites, and I think it's 25 or 26 service delivery organizations. And we can talk later about scalability, but that's part of a national safety net of over 9,000 sites, and by far the largest primary care distributed network in this country. That has as its core reducing, measuring and being held accountable for those racial, for those health disparities that exist. So I think it's really it's an important part of what we do. It really is a system that where the voice of the community is represented. I'm proud to say that it's been extensively studied, and in distinction to I guess I'd say in contrast to Carol and Erica, who have been incredibly innovative in new design and programs, the health centers and what I do has been around, is actually old and innovative. This is a system of care that's been around for 50 years. It's basically all that's left of President Johnson's war on poverty from the mid 60s, and we're still kicking. At its core, we will come. I'm sure we'll circle back to the Accountable Care Act and the opportunities that it's provided to provide basic health security for a lot of people in this country. But at the end of the day, we serve that expanded population of Medicaid and the exchange. But we are here to take care of the left outs, and that voice should never be left unspoken, because that's still 30 million people here in this country that are left out for reasons that are often beyond their control, and the health and the community health centers is a system that is here, I'm very proud to say, to serve them as their core value. I go to work every day, and I like to say in the context of this campaign that I have the best job in the world. I love what I do, and the beautiful thing about this audience is many of you will say the same exact thing, despite the fact that we're in pretty different practices, and we have different patient populations that we serve. This is the best job in the world. I love going to work every day. I love chipping away at unfairness, providing some measure of health justice, and I happen to be privileged to work in a system of care that's designed to do just that. I circle back to the mantra. The mantra is the mission. The mission of my organization is to provide primary health care to improve the health of our community by providing culturally appropriate, cost-effective, high-quality primary health care services, regardless of ability to pay. That's it. I walk in the door every day. Well, I could be mixing it up, but the mission is to improve the health of our communities by providing high quality, culturally appropriate, cost-effective primary health care services, regardless of ability to pay. And I'm so proud of that, not because I made it up, because I didn't. It strikes a chord in me. It strikes a chord in all of you. But at the end of the day, that was sculpted word by word. I was there and I watched it by our community board of directors, my patients, my indigent patients. At the time that I looked around the room at the time that was refined, because it's continuously refined, and I looked around the room. There was a patient of mine who had nearly died of HIV infection. There was a homeless person that was in transitional housing. There was a uninsured diabetic who was, we brought back from the brink of losing a foot, et cetera, mentally ill person in recovery, in addition to pretty high-powered people who we recruit to that board who have basic medical and legal and government affairs types of skills. But that's the voice of the community, and it's them deciding what those health disparities are, and very importantly, holding us accountable for improving them.
Dr. Covert used the term health justice, which clearly is a driving force for you. What does it mean?
It's just basic fairness. It's just that we all know this. Health is a right. It's not a privilege. That's a tired phrase, but it never should be. Everyone has the right to basic primary security in their health.
But not everybody in America gets it.
Not everybody gets it, but that doesn't excuse us from the task of trying.
Yeah. I thought some of the things you said were echoed by what Erica said to us, the way they have set up a practice that provides a lot of care to Medicaid patients. And they were working on a model kind of based on concierge medicine. And I've been taught that concierge medicine is a bad word. You know, this is where doctors take a certain amount of money to treat rich people, but you're doing it differently, Erica, is that right?
Yeah, we used to say it's concierge care for the rest of us. But, you know, it's kind of interesting. We think of, I think the problem with thinking about it as concierge care is the notion that it's unreachable and affordable to all but a very small segment of society. But if you think about it, that's really the care that everybody deserves. So one of the things I love about my practice is that it's so varied. It's really challenging, actually, to take care of a very socioeconomically varied population. You know, I have folks who are literally homeless and people who are multimillionaires with jets and everything in between. And let me tell you, it really focuses the mind, and you realize how much you assume about people when you have to stop and think about every single individual. And it's been a great lesson to me about the marriage between thinking about populations of people and thinking about you know, health injustice and disparities in populations of people, but then bringing it down to the personal individual level, because that's always what you have to do, one by one. Health care, the medical system is about one-by-one care, no matter what you do. Public health is about, you know, really all of society and the health of the public. And there's an intersection between those two. And, you know, we have to be able to solve for disparities at a systemic level and also at an individual level. And that's what I have really enjoyed about our practice, being able to take on Medicaid. And we're trying to prove that you can actually do it. You can save the system money, you can make the care better, you can make it a reasonable, rational payment structure that doesn't impose undue burden on the practices, that actually robs money that is supposed to be spent on caring for these folks, you know, precious resources that really should be directed to their care, not to all the administrative overhead that oftentimes goes into it, even for these programs that are designed to distribute justice.
Yeah. Richard, in these community health centers, all the ones I've been to, I think everyone I've been to is headed by or maybe completely staffed by a primary care physician. Do they have specialists too, or is there a need for that?
Well, you know, if you've been in one community health center, you've seen one community health center, and we all come up with a different formula that's responsive to the needs. There's some that have, it's rare for the tertiary care specialists to be there, but many times we get volunteers. What we've done effectively in most parts of the country is we know we can't do this alone. There is more than primary care, especially to taking care of sicker populations. And we collaborate. We work with the rest of the healthcare system by providing that primary care base. It's a stronger argument to collaborate the care with specialists. Here, we have great models of collaboration with local care partners here that provide that advanced care. Sometimes it's not, it's not all family physicians. We have nurse practitioners, we have physician assistants. Some places employ pediatricians, some obstetricians, but overwhelmingly we are family physicians staffed in the system of care.
Going back to what Russ told us, should a community health center have a behavioral physician?
We do. And certainly all community health centers are in various stages from getting started to advanced of incorporating behavioral health components. It's really what we do. And to be fair, public financing helps support that effort to actually integrate. When you talk about health disparities, people who have suffered that health injustice for a long time have a lot of health issues that are pent up. There is no physician alive that can address those as an individual. And really what we're kind of talking about in other areas is the family physician as, in many settings, as leader of a healthcare team that collaborates and coordinates care with care partners. Most importantly are our behavioral health folks so that we can provide comprehensive care. So yes, we do have them on site. Yes, it's a very, very sophisticated program that does population management with people with various mental health concerns.
So we've promised we're not going to be political today, but I do want to ask you, has the Medicaid expansion made a difference in your world?
Medicaid is something that just needs to be said, and here's how it goes. This is, for me, I live in a country where I hear Medicaid, the term is almost disparagingly used. To me, Medicaid, federal Medicaid program is nothing short than of a fair and reasonable and reliable care partner for my patients. I'm able to provide comprehensive care because of the Medicaid system. It is something we should be exceedingly proud of. And Erica has been innovative in tapping into that. And I don't know what her arrangement is with the Medicaid Managed Care Organization, but it's there, and she's able to provide this care and all her great services to that population. Everyone deserves access to that. To be fair, there's a different reimbursement formula for federally qualified health centers. That, by the way, I don't just get that because I'm a nice guy. I get that because of the accountability, and I get that because of the unassailable rule of patient majority management of the health center. But we have a fairer reimbursement, so we do not lose as much resource by taking care of that population. And that needs to be addressed. It is being addressed, but it is the core of what we do, and it enables us to provide more care to the uninsured, the left outs.
So in Washington, how much does a qualified health center get for an interaction?
It's something, to use the simple term, we call it something like cost-based reimbursement, though the terminology has changed. But this is what it costs to provide care. This is the budget. This is the number of patients and visits. There's a formula, and that's what it costs to take care of the patient. The Medicaid agency, in the state of which we have 5, reimburses us at a certain rate that's not very different than what the private practitioner gets for Medicaid. But then by federal law, the state has to formulaically reimburse us the difference for our costs. And again, this is not designed to give, just as favoritism. It is designed so that we don't have to use our federal grant dollars that are focused on the uninsured to subsidize the Medicaid system.
So in Colorado, we just raised the basic consultation fee for a Medicaid visit. It's $208 at a health center. I think for a private doctor, it's $38 or something like that. But a health center does pretty well on this, and it's a good idea. It funds this kind of operation.
It funds the multidisciplinary care.
Carol Heyman told us, I really like this about primary care doctors. They always say this. I don't see this patient as a list of problems, she said. I don't see this patient as a broken joint, but as a human being, as a person. And Carol, you're dealing a lot, mainly with seniors, is that right?
That's right.
And is Medicaid an impact on you too, or are they all Medicare?
Well, they all have Medicare. Now, they can be dual eligible. In other
Yeah.
words, they can have Medicare and Medicaid.
That's complicated, right?
Yeah, I mean, so they can, but they tend to be old. They may be old and poor, but they tend to be old.
Yeah, yeah. And is Medicare paying you fairly?
Just say no.
Yeah, so Iora's model,
Yeah.
so Iora's new to Washington State, and our clinics, we have 2 in the Puget Sound area, mine in the Central District and 1 in Shoreline, are the first, and then we also have 2 clinics in Phoenix in Arizona. Those are the first Iora clinics to contract with Medicare. So it's brand spanking new. We've been open since October, so I don't have a lot of data yet to tell you whether it's working or not. But basically, the Iora premise, similar to what Erica talked about with Q-Liance, is that we need to be funded differently than in fee-for-service model. So we've never done fee-for-service, and we never will, which has allowed us to be innovative. And so you need payer partners who share that vision and believe with you that if you properly fund primary care and you let the primary care team do their work, you're actually going to save on health costs, overall health costs, which
Well,
of course
you know,
Medicare would like.
Anybody who's looked at health policy knows that's obviously clear. It's clearly a rule that where you emphasize a system that emphasizes primary care has better health outcomes at lower cost. We know that, but do your payers know that?
I would say yes. The people who are willing to, who've partnered with us, they're betting on it. And IORA's had great success with other populations, unions, employers,
Right, yeah.
other, that's been very successful. My feeling is if we can show this for the Medicare population, for our aging adults that have high costs and are poorly served by the current system, now we're playing ball.
Yeah, and then you can spread
now
it to
we're
every- yes.
then people can't say, oh, well, that's just true for carpenters. Which, we have the Carpenters Union in New York.
Yeah, yeah,
Or
fine.
that's
Yeah.
just true for casino workers, because we have the Casino Workers Union in Vegas. If we can really talk about, no, I'm talking about Medicare patients.
Yeah,
And
yeah.
so I think it represents a lot of hope for
Yeah.
what we're all trying to do.
Yeah. So I wonder, do you think casino workers have more behavioral problems?
Yeah, we have
Interesting
it's
Yeah.
a lot of great stories from Vegas. Whew.
question. Erica?
I just want to weigh in a little bit on the payment thing.
Yeah.
I think there's some basic principles that we must get across to our country, which are the old saying, an ounce of prevention is worth a pound of cure. And people do not want to be sick. They would like to have all that prevented. Like I said before, people don't want health care in the first place anyway. One of I think the battle that we have entered into at Q Alliance, IORA, and some other folks is to demand of the system that it make the proper investment in primary care if they want to get the results that they say they want to get, and really challenging the payers to say, put your money where your mouth is. So when you ask about are we being paid fairly, it's a struggle. People give a lot of lip service to, oh yeah, primary care is great, you guys are awesome, all the data shows that you can make miracles happen, hallelujah. And then you sit down at the table across from them to negotiate, even with proof. I mean, we've shown across the board about a 20% net savings in our populations with this model. And we're just getting started. We don't even have all the data we need to be able to really address their needs. Even with that, when it comes down to the negotiation, there's sort of a nervousness of like, but what if it doesn't work?
Yeah.
We're scared. We don't, we can't get the actuaries on board and all that. So a few payers are stepping out of the huddle and saying, we'll take a chance, but it's a process and it's going to take some time before we break out of that mentality and also invest in changing the payment systems so that they work with this model of care. So we're not there yet. It's not easy. I know our companies negotiate all the time trying to get this to change, but we hope to be the point of the spear to get this going.
Yeah, well, it seems to me if you're into the business of paying for health care in America, we pay more and get less than any other country, so they ought to be looking for something new. And what do you find? Are they receptive or scared or?
They're becoming more and more receptive. I'm very optimistic. I think that there's been a huge turnaround. I think being able to work with Medicaid was, it really finally dispelled all the myths of concierge medicine and that we were really out for our own best interests and
Yes.
didn't care about the public. So
That's what I thought.
I'm very, I love the ACA. It's been really great for us. So because it's given an opportunity to not only just get people covered so that, and I'm not a big fan of health reform being just about insurance reform, but I'll take what I can get in terms of
Yes.
opportunities to make change. So now we're finding, I'm getting inbound calls now from payers saying, hey, we heard about what you did. It's really interesting. Could we work with you? And it starts the conversation. Like I said, lots of grinding and machinations to get to actually working together. But it's starting to really pick up steam. There's a ton of interest around the country. And doctors want to practice this way. They call a lot too.
Yeah,
Yeah.
that's very true.
There was a fabulous article in Time Magazine about Qliant that set it up as a model for the whole country. So what happened after that? Everybody called or?
We got some interesting calls, actually. It was fabulous. I mean, we got everything from people literally just sending emails or leaving voicemail messages saying, this is so great, keep going, we need this, which was wonderful to hear, all the way to all kinds of interesting potential partners. And I even got a call from the military saying, we know we have a huge problem in our healthcare system and we got to do something different. They're even looking for alternative models of care. The most exciting to me though was people just, individual people from around the country who got in touch with us to say, this is great, when are you coming to my town?
Yeah, Yeah, and what's the answer? Are you going to other towns?
We are trying to expand. We are planning to expand to other states. Like Iora, we are trying to create a national model, and we're sort of friendly co-market makers, we call ourselves, because we're trying to. I think if we can get into several markets, it kind of sets some momentum in motion and will bring others along. It's kind of like any new thing. You have to kind of break it open and get people to understand there is a different way of doing things and have some success. And then it makes it safe for other folks to come in. But yes, we plan to go into other states and continue to work with Medicaid and other payers.
Yeah, I got a little ahead of myself. I want to get to that point later, too. So, Richard, does every state have federally qualified health centers?
Again, this is that question of scalability. What started off as 2 demonstration projects, 1965, has grown to a network of 9,000 sites, 1,400 organizations in every state and territory.
Now,
Funded, by the way, by about less than $3 billion in federal spending, and it's always helpful to put that up to the kind of money that was spent on the TARP, the bank bailout.
yeah, absolutely.
And the other piece I just wanted to throw in about this Medicaid, the one more piece, right? This is where we all have, and this is about family docs. It's not about payer systems, but according to the Office of Management and Budget, $1 spent in my system of care on the Medicaid program returns $3. So it's that kind of benefit. So in that spread between that 1 and the 3 is the ability to provide fairer reimbursement for my other colleagues that would love to take care of this population.
And if I could echo off
Yeah.
of that, being in a community health center also, the greatest growth in the community health center system occurred under the Bush administration. This is not a Republican or Democratic issue.
Yeah.
This is for the health of the country that makes sense.
You mean because they saw the value and put money into it? Is that what happened?
Yeah.
Yeah.
It's every district has a community health center and people vote, and this is one program that has broad bipartisan support on both sides of the aisle for different reasons, but broad bipartisan support.
When we talk about health disparities, clearly there's this economic disparity. There's also a geographic disparity in access to health. Richard, is that or?
Well,
Matt?
absolutely. So when
Russ?
I talk about, again, my system of care, half of the providers are actually in rural areas of our system. Half of those providers work in rural America, and these are very difficult places that are economically disadvantaged, as well as geographically isolated. And this is the system of care, including often the specialty system of care, for lack of better solutions to provide all the care in those communities.
A primary care doc is doing.
Family doctor in rural America
family doctor,
is what we've got.
Yeah. This is striking, and this is another reason why health is primary, why a country ought to put more emphasis on primary doctors than America has so far, because in these areas where there aren't any doctors, the primary doc is healthcare. I'll tell you a story. When I was a reporter, I was covering a story about the shortage of doctors in rural areas, and I went up to eastern Wyoming, Wheatland, Wyoming, Chugwater, Wyoming, Douglas County, Wyoming. There's a lot of land there. There are a lot of windmills and very few people and very, very few doctors. So I went to visit this family doctor in Wheatland, Wyoming, to talk to him about his practice, and called him up, and he said, yeah, come on up. I said, I'll take you to dinner at the best place in Wheatland. And he said, well, that would be the cafe at the Esso station. And so we went to dinner with this doc, and he told me about his day. He had started his day at 6:30 a.m. He delivered a baby and kept going. At 6 p.m., he made his daily visit to the Senior Citizen Center. So his patients that day ranged from 1 minute to 99 years old. That was his practice. And while we were talking, he kept looking at his watch. He said, I don't have much time. I got something important to do tonight. Well, what is it? And he said, there's a big high school basketball game. Very important game, Wheatland High versus Chugwater. And they're 60 miles apart, but in that region, those are the close rivals. We got to go to the game. And I said, well, I'll go to the game with you. That'll be fine. And so we're walking into this high school gym in Wheatland, Wyoming. And I said to the doctor, which team are we cheering for? He said, you know, I don't care. I delivered every player and every cheerleader in both schools, which is why primary care is really filling this very important disparity, this geographic disparity. And the question is, how do we produce this primary care workforce? How do we convince young people that this is the way to go, and how do we then get them to work in rural areas? And for that, I want to turn to Dr. Tom Norris, who has been working in this field for a long time. Tom?
Thanks very much, TR. As you've heard from my colleagues here, my friends, there are a lot of different ways to do primary care. And one of the things you've been hearing a fair amount about is the problems with how we get paid, and the fact that getting paid per visit doesn't work very well. And part of the transformation that needs to happen is getting paid for the value of care. The other big problem we're dealing with right now is who's going to do it. Where's the workforce to accomplish the work that needs to be done? TR told a wonderful story at the beginning of how he brought Ichiro to Seattle, largely because there was no one playing baseball and we could concentrate on something else somewhere else. Well, we've got the same problem in many places with no one doing primary care, and it's a significant problem. It's an important problem. If you look worldwide, in places where the ratio of primary care providers to specialist providers is 2 to 1 or even 1 to 1, the health care and the health statistics are significantly better than they are here. Here we have a ratio of roughly 2 specialists to 1 primary care provider, and it's worsening, not improving. And at the same time, our health statistics are worsening and not improving. The more primary care you have, the higher percentage of primary care providers you have, the better health you have. If you look across the United States, there are a lot of areas that are short of primary care. And you've heard about 2 of them, Wheatland, Wyoming, and the community health center populations of patients often in urban underserved areas. There are not enough U.S. medical students interested in going into primary care. Well, why is that? You've heard the folks here today talk about this is the best job in the world, and I believe that. But why is it that more of our students don't want to go into it? Well, I think there's several reasons. It is a hard job. It's hard work. It's the doc in Wheatland who delivered a baby at 6:30 in the morning and saw the senior center at 6 at night. There's too much time spent fighting with insurance forms and pre-approvers and other groups of people who interfere with us trying to do the direct care for our patients that Erica is talking about. Those things lead to frustration, and they often lead to our docs saying to students, you really don't want to do this because it's hard. And that's a problem. The second problem is we get paid less. We get paid less than a lot of our specialty colleagues do. And our students are coming out of medical school with big debts and saying to themselves, how am I going to pay these off? And looking at a lower paying career that still pays plenty is something that is not as attractive. And third, we live in a place where there's been less prestige for primary care family doctors than there has been for heart surgeons or brain surgeons. So we've got some things to deal with in terms of system challenges that face us. I want to tell you a story about dealing with one of these in the 5-state WWAMI region that was talked about earlier. Our region has a lot of rural spaces, and if you look for shortages of physicians in our region, the rural spaces often are the places where you see the shortages. One of the things we discovered is that over time we were seeing fewer successful applicants to medical school from rural places, and we were seeing fewer people going from medical school and residency to rural places to practice. And the question basically was, what can we do about this? We had little pieces of programs that looked like they helped a little bit, but we tried stringing them all together. We came up with a program that we call TRUST, the Targeted Rural Underserved Training Program. And Trust is a special program that admits students with a separate admission process who grew up in a rural place. Our data showed us that if you grew up in Manhattan, your likelihood of ending up in Two Dot, Montana was low. The thought here was, okay, well, let's admit preferentially students who came from a rural place. These folks are just as smart and meet the same standards for admission that the other students do. Maybe they don't have quite as high in numbers on some of the tests because going to high school in Wheatland and going to a community college or a state college might not give you the same test-taking ability that going to Stanford gives you, but you're still going to be a really well-qualified medical student. So a special admissions program for people from rural places. Right after they get admitted, we assign them to a small town, and that small town and a small town physician and a small town group of patients are their learning laboratory throughout 4 years of medical school. They reconnect and reconnect and reconnect with that small town. They go back for weekends. They spend some time after the first year of medical school. Hopefully we can do some of their third year clerkships there. So throughout all of medical school, this connection exists. It's not a matter of living in the big city and deciding, gosh, I need to live here because they might not have enough Starbucks facilities in the small towns. It's a matter of staying linked to where you came from, to your roots, to your legacy, and that's paid off. At the same time, we overlaid it with a number of sequential educational programs for the students about things like what are the demographics of rural places? What are the disease patterns one sees? How do you manage chronic disease? How do you work with a team of people that may include your pharmacist and your social worker and the folks who work at your nursing home and your football trainer? How do you put all of these things together in a way to make it work? And we've put this program together. It has resulted in a group of people who graduate from medical school. They don't all go into family medicine, but they tend to go into things that allow them to practice in rural places. We need rural psychiatrists and rural general surgeons just as badly as we need rural family physicians. These people end up doing residencies. Hopefully the residency program allows them to stay linked with their small town, and we're beginning to see them go to the small towns to practice and do what we hoped they would do, which was to fill the gap in workforce. As we've done this, we've learned some things. We have to be innovative. There's a sign over here on the wall about the importance of innovation in what we're doing, and we have to be innovative. We're putting a new curriculum into our school, and one of the things that one of our faculty members is working on is creating a primary care practicum, so that starting the first week of medical school, you start working with the primary care doctor, and you continue that through your basic science years at the beginning of medical school. We're working hard with the residency programs. There are more new primary care residencies in the Northwest than in the rest of the country. And the reason is that we've got a team working with a network of primary care residencies, helping each other through our strong residencies to create new ones. So being innovative and being committed to educational innovation works. Trying to see the problems, trying to use innovation to solve the problems, I think is going to help us get to the place where health is primary, won't be dependent upon can you find someone to do it.
How big a town does it take to support a doctor?
The data varies a little bit, and probably somewhere in the neighborhood of 1,500 to 2,000. But
really?
It's been said earlier that healthcare comes in teams. And I can think of a lot of places where a town of 1,000 has a physician assistant who works with the group of physicians 10 miles down the road in a town of 3,000.
Yeah.
So there are a lot of different ways of doing this.
Russ, east of the tip of the Cascades, can you get doctors out there? What are you doing?
It's interesting. You can divide Washington up into two states, Western Washington and Eastern Washington. And Eastern Washington looks like Idaho and Montana when you look at physicians per thousand. Yeah. So it is tough to get folks to those areas. It's interesting, you know, several folks here are connected with residency programs. If you look closely at those names, they're basically ex-hospital residency program. We have some real problems with the way we fund graduate medical education or the training of resident physicians in this country. The dollars to train those physicians are linked to hospitals. And they're basically linked to large hospitals. Even if you have a small rural hospital, so more than 25 beds, there's sort of two types of rural hospitals. There are rural critical access hospitals, which are 24 or fewer beds, and then rural hospitals that are bigger than that. Even those larger hospitals receive disproportionately less funds for support for rural training. And I would actually, having grown up in a smaller town, would consider some of those hospitals not even truly rural, but that's beside the point. Rural is also, there are some federal definitions, but there also are some personal definitions of that. So one of the really beneficial things of the Affordable Care Act is essentially the first time since the 60s and President Johnson's War on Poverty and creating funding for graduate medical education training was new funding for residency training. Currently, our system, most residents are funded through Medicare and Medicaid. And that system of funding basically writes about a $15 billion check to hospitals and says, train doctors. It's the end of the accountability. How those dollars really all get spent, there's some accountability for some of those dollars, but a largest portion of those dollars can actually be spent on new cancer wings or a fountain in the courtyard, and that is a legal use of the funds. The
Fancy cafeteria?
Yeah, fancy cafeteria with really good food too. So with the Affordable Care Act, a piece of that legislation was a model project called Teaching Health Centers. Teaching health centers can be in a tribal clinic, can be in a rural clinic, can be in a community health center, and most of the teaching health centers are based in community health centers. So I practice in a community health center. It's not owned by a hospital. There's some barriers between that. And by jumping through all sorts of hoops, we were able, though, to access these funds. What's really marvelous about these training funds is they allow us to train the doctor where I want to send the doctor, not where Medicare says that doctor needs to be. So I'm sorry I'm getting a wee bit into the weeds, but it is a crazy system that we have out there that says, here's the dollars to train doctors, but you have to do it in the hospital if you want those dollars. Yeah. Our system, as you told your story, Tom, about eastern Montana, is the training they need is not in a large urban tertiary hospital with 800 beds in every service under the sun. If you grow them where they'll practice, they are very likely to stay there. Tom Norris alluded to sort of the makeup of a medical school class and how that really doesn't match those needs as well. So if you look at the Teaching Health Center program, one of the things I'm obligated to do is report to the feds where my residents come from, what sort of backgrounds they have, what things I have in the curriculum. So I can tell you half of my residents, not just my Teaching Health Center residents, but I think in part because we're based in a health center, half of my residents come from a disadvantaged background. If you parse that out, there's a number of things that make up a disadvantaged background. If you parse that out, the number one and number two most common reasons why they achieve that designation is they're the first in their family ever to go to college. So if you're looking, as Tom Norris noted, some of the hurdles of getting into medical school, if you're the first to go to college, there are a lot of hurdles. The second is a rural background. So 20% of my residents come from a rural background. That's higher than the percent in the general population. And 17% of my residents come from underrepresented minorities. Just for fun, I tried to look up what percentage of disadvantaged applicants make it into medical school. I'm not super skilled on searching the internet, but it was pretty easy to find a hit about Harvard. So, more than 10%, more than 5%, or less than 1% at Harvard are from a disadvantaged background. In medical school. Less than 1%.
Yeah, I bet that's true.
So if we're looking for doctors in rural areas, we need a whole pipeline of medical schools that are recruiting folks who are likely to go to those areas, and then training sites that can train them in those areas. Outcomes of that program, it's fairly new. We've just had the first classes come out. Actually, the University of Washington several years ago funded a study looking at who ends up in health centers like Rich's and mine. One of the best predictors is someone who actually trained in a health center. So of my 2 graduates last year through the Teaching Health Center program, both of them ended up in health centers. One, Marianne, grew up first in her family to go to college, grew up in inner city Portland, immigrant family, and has gone back to work for the health center that was 2 miles from where she grew up. Another one's also from an immigrant family. Family ran a mini mart. Sorry, I had to think of the right word there, not a 7-Eleven, a mini mart in Wenatchee. And he stayed in Central Washington to practice. So we have some models out there that are really, if you look for bang for your buck on your tax dollar return, do you want your tax dollars going to write a blank check for $15 billion to large hospitals to train folks for which there is no accountability and no outcomes? Or would you rather your tax dollars go to support training primary care doctors in settings where they'll actually practice? So I'll leave you all with that question.
This is kind of privileged information, but I happen to know that Dr. Erica Bliss was one of the top students at her med school. And what did they say to you when you said you wanted to do primary care?
Well, I entered medical school pretty much with this stamp across my forehead that I was going to go into primary care. And the day I set foot on campus and looked around and said, well, what specialties would make sense for me? Family medicine was the only one. So I literally started medical school, and I was a late entrant. I was 28 years old, so I was pretty set in my way, more set in my ways than maybe I would have been otherwise. All through medical school, and I'll name my school, I was at UC San Diego, so a state-supported school, with a mandate from the state of California to produce primary care providers, physicians. And continuously throughout, I heard from all kinds of people, family medicine, really? Why would you do that? And all the way to the end, and I was out there. I mean, I was involved in a lot of family medicine organizations and leadership and programs, and I had my scholarship profile was all about doing primary care. I committed myself to it after residency, and I sit down with my dean of students who went through the dean's letter that you get to go to residency, and she said, you did a great job, good job, this is great. And then at the end she says, I just have one question for you. She was with infectious disease doc. Family medicine? Literally that disparagingly, and I just looked at her and I said, are we done here? That's the problem. I mean, I made the comment to TR that is really, as taxpayers, we should be outraged. Those folks should be fired. They have a mandate from the state to produce primary care physicians, and they're just actively discouraging them from doing it. And I know this still goes on today. We have to root that out. It has to be, not that we should try to make people think that it's all wine and roses, but we certainly should not be actively telling people not to do it.
But don't we have some newly minted MDs in this room? Is this still happening at med schools? Are you still discouraged from, yeah? Why, are they thinking money, or what are they thinking? What do you think, Tom?
I think a lot of it has to do with prestige. I think that if you graduate a lot of people who become on-campus research scientists, which we need, then you end up with more Nobel Prize winners and things of that nature, and more prestige for the institution. I think that it's hard for institutions to remember that if you ask the legislators why they're there, it's to train doctors to work in the towns where the legislators come from.
Yes.
And I think we have to keep reminding them of that.
Okay, thank you. Yeah, you said east of the Cascades, that's a different state?
Yes.
Yeah. I used to be you don't want to hear all my stories, but I used to be a reporter in this region and was covering the Rocky Mountain West in the Northwest, and at that time, maybe this is still true, there was a movement that eastern Montana, the panhandle of Idaho, and western Montana, panhandle of Idaho, and eastern Washington were going to secede and form the new state. Some people called this the state of Columbia. When I was working on this, they wanted to call it Wash-Tanahoe, the state of Wash-Tanahoe.
Although it's a different state, I'd rather be paired with Western Washington than the Panhandle.
You don't want the panhandle of Idaho, really?
Economically.
Now, you know, we have been looking at these new ways to deal with health disparities, to provide a sort of a broad range of care to a whole patient and not just to one organ or one joint. New ways to kind of produce the workforce that our country's going to need as we expand healthcare coverage in a country that still doesn't cover everybody. And one of the ways that healthcare is being transformed is through new technologies. And so I'm kind of interested in the impact of that kind of technological innovation on our effort to promote primary care. And Glenn, you studied informatics, is that right?
Yes, sir.
So what's going on with the technology and its relationship to primary care?
Well, as happens so much in medicine, I think that we often see the technology get ahead of our ability to use it and understand what its role is and how it can actually contribute to health. And so we often implement technology before we know if we should. And so our project really is focused on two aspects of technology. We think it's a very fundamental part of our efforts to contribute to improving the healthcare system, both in the care delivery, in the economics, the efficiency, but also in truly improving health and the professional satisfaction of physicians. You know, one is the health technology that physicians use. And what I always like to say is I don't care what EMR you're on, what version your provider says it is, it's 1.0. They are very crude. They were built by programmers, and they do what they're supposed to do, but not in an efficient way, not in a way that corresponds with the best care of the patient, the best flow of a visit, the best thought process for a physician. And so we very much want to be a collaborator with technology companies, but our other colleagues in other specialties and in other health professions that use these tools, and figure out how can we collectively be a voice for improving that, so that it's not the visit with the eye doctor, which is the eye doctor, which is the doctor facing the screen while the patient wonders what's going on. We really need that technology to be contributing to rather than detracting literally from that interaction with the patient. And then there's a huge explosion that's begun but really is just starting, and that is of wearable and implantable technology, and that has, we believe, ability to contribute to people's health, but only if it's applied in some strategic and coordinated and thoughtful way. You know, technology for technology's sake is rarely something that ends up with value. So we feel that there's a leadership role for family medicine and primary care to take in consumer-facing health technology. Your Fitbit, your whatever device. I'm going to buy that new iWatch that day it comes out, I tell you. But the studies show that people use them for 2 or 3 months and they quit. And that's, you know, the statistics, majority of people quit using them, and it's because it doesn't actually provide value. Well, I think that physicians and this medical home team model, it's probably not that they're sending their data to me, it's they're sending their data to the medical home, to that health coach that Carol described, somebody who's monitoring that, and it's filtered in some way where you're not looking at every data point, but worrisome trends, values that are out of range, and reaching out to patients about, I see your weight's going up, or you've been less active, or, you know, whatever the metric is, and engaging them between visits in a proactive way to improve their health. And as others have said, our payment model for healthcare currently doesn't support that. So we also sort of look at the technology that's available and wonder why more physicians aren't using it. Well, in primary care, the funding model doesn't pay enough to buy that infrastructure, and so we need that payment that is more patient and service, unit of care being a month or a year based that includes whatever technology it's going to take to care for them.
Well, if I send an email to my doctor and say, "Doc, that pain in my shoulder is back today, what should I do?" Does she get paid to answer me?
In most systems, no.
Should she?
Absolutely, she should. It should be part of providing the care of what you need. I would make a distinction. There's a lot of disruptive technology out there. We'll see how it goes as far as telehealth. I would say that shouldn't be to somebody you don't know. I've got a pain in my shoulder, what should I do? They don't know you, you don't know them. It should be incorporated into that, as we've talked so much about, that continuous caring relationship between you and an established care provider, so that they're doing that remote care based on that fundamental knowledge of you as a unique patient.
Yeah, so if you think about it, that's another reason why primary care is so valuable, because I know my primary care doc knows me and my shoulder,
And your family and your community situation and your family history and all of those things that incorporate what's the best possible care for you as a unique individual. And you are unique, Tom. And you haven't even mentioned snowboarding yet, and I'm so impressed. We're a couple hours into this, and you haven't mentioned snowboarding.
I'm from Colorado, of course I'm a snowboarder. Devin, are you using some new technology in your practice?
Yeah, we're in the Providence system. We're sort of all in with Epic, and Epic. The big dream of Epic is that it becomes one platform across all kinds of different services and specialists and locations. One chart, one patient, regardless of who's trying to access it. And me personally, having gone through a couple of EMR. Integrate with Centricity and then changing to Epic and then upgrade for Epic. It's actually created a whole lot of headaches, but part and part, it's improved the relationship that I have with my patients. Just last week, a patient of mine who's young and overweight and diabetic and resistant to going onto insulin, which is what she needs, is very, very nervous about that first shot, the first injection. We have an integrated pharmacist who's kind of working with her. She's not ready for the first shot, and I've had probably 7 or 8 emails with her in the last 10 days, just helping to coach her and talk her down and not have her cancel the appointment. When I asked her what would it take, she said it would help if Sherry were there at the appointment when I do my first shot. Sherry is our medical assistant who's been there for 15 years. She's actually become a nurse more recently. And I could redirect her email to Sherry and say, could you be there next Tuesday at 1:30 when she gets her first shot with the pharmacist? So it's just a very, very concrete example of how technology and Epic really has helped connect that patient to me and our practice and the healthcare team.
She's scared of the medicine or getting a shot?
The needle.
The needle.
Yeah.
And eventually she's going to have to do it herself, right? Is that right? Or?
Yeah. I've known her since she was about 7.
Yeah.
She's 18, and she comes from a large family of diabetics, and I know her extremely well.
Carol and Iora, would you get paid to answer a patient's email?
Yes, because we're paid just to take care of the patient,
Yeah,
so
so
we can
that
do whatever.
system
And Iora is actually originally a Boston, Cambridge, Massachusetts is where they live. So we actually have a bunch of MIT coders who write most of our EMR. We actually have a proprietary EMR that was designed really for primary care. It's actually very simple. It's very patient-facing. It doesn't do a lot of the stuff that Epic can do. Sometimes I honestly miss some of the things that it can't do, but the simplicity really allows it to be useful as a communication tool with patients. And I think that the best use of technology is really to think about bringing down some of the barriers between the patient and their primary care team. And technology can help us do that kind of in some simple ways. Erica said last night, or earlier, that sometimes technology includes like the telephone, right? It doesn't always have to be hard stuff. But we have, for instance, I keep my EMR on a laptop, every team member does, and when we go in a room for the patient, we have a big screen mounted on the wall and a table in front of it, and I plug my laptop into the screen and share my screen so that the patient and I, just a simple sort of architecture thing, this patient and I sit together in the room and we have the screen there, and so we can really, everything that I type, they can see, which I gotta be honest, sometimes change is what you type. But they can really sort of feel part of their care and their record, like they own it, and it's really sort of part of how we're doing care together. Having that big screen that I can see, even with my older patients who can't see that well, also has sort of opened me up to using other things. Like I've started using Google Images a lot if I'm going to show them like I say, I think, oh yeah, that on your joint, that's a ganglion cyst. It's not to worry about. Wait, let me show you some pictures. Look, here's somebody else with a ganglion cyst. They don't have to worry about it either. I can actually, Google is your friend, right? I can actually sort of, give myself some credibility every now and then, and that's nice. The other thing I used it for last week, I had a patient who was fairly new to me, but sort of right when we met him, he was going into his terminal decline, and he's dying. And he's been at a nursing home, sort of hospital, skilled nursing facility, and then back at the skilled nursing facility. And the staff there had said, we should put him on comfort measures. We shouldn't put this guy in the hospital again. It's not going to help. Family was having some trouble coming to acceptance with that, with their loved one, and they really wanted to bring him to me for my opinion. So they arranged transport, but the daughter, who's the healthcare decision maker, is in California. And so I did a Google Hangout with her and put her on the big screen. It's like we Skyped her in, and she was right there. It really felt like she was right there with her mom and her dad and the caregiver and me and my health coach and the daughter. And we were like there in the room together, and that was just, we really had a difficult, important discussion about her father being on the brink of death and what I thought was the best thing to do, and they all came around, and there was all the stuff that really matters in a medical encounter, crying and hard decisions and tough stuff, and we did that because we had some technology available that let us. It was cool.
Devin, if I'm on EMR and if I'm on eccentricity and you're on Epic, or eccentricity.
No, eccentricity.
Eccentricity. If I'm on GE and you're on Epic, can I send my patient's record to your system, or?
No.
Yeah, so is this nuts?
There's people coming from one Epic system to the next Epic system still walk in with all of their records printed from Epic for me to review and then scan into my Epic so that I can not look at it later.
So, I kind of hate to say this, we're in the United States, we don't like government, but should the government set standards so that all these systems can talk to each other?
Well, I'll jump in on that. Absolutely, yes.
Let's hear you. Yes? Yeah.
It would be a simple thing to require a common database. Who cares what the overlying interface looks like? They can compete on the interface. But if it's a standard database, then everything is interchangeable and portable.
So is this in the works, Glenn? Are we going to get to some kind of standard?
Well, there's standards, that have been developed and development's ongoing. The challenge is that they bring some of the standardization we look for, but they also potentially stifle innovation by locking you in where you are. The level of portability between a single type of database and putting different front ends on it is challenging because we don't always have a single coding language for what different medical terms and things mean, and so it's hard to put them on the same database when they're actually speaking different languages. So it's one of those things that's always more challenging than you think. And then of course, there are substantial proprietary forces at work where some companies are very happy that their platform does not talk to others. I know Tom's involved at the university in informatics and probably has other things to offer too.
If you want some examples of how it could work, look at the Veterans Administration system. And when Hurricane Katrina hit New Orleans, a large number of veterans migrated from that area to other areas to get their care, and the database was intact. The people who saw them could access their lists of medications and problems and everything else, and it was pretty seamless. It was a VA-based system that they had developed and was in use at all the VA facilities. Similar characteristics in the U.S. military systems. You can bring somebody from Afghanistan to Madigan Army Hospital, and the information from one place tracks the information to another place. One can argue, though, that those systems are more rigid, less flexible, less innovative, and they don't make somebody as much money as the multitude of proprietary and commercial systems that we have out there. Eventually, we're going to end up doing what the telephones and the railroads did, and getting to the point where your GE telephone can talk to my Motorola telephone. But we're not there yet.
How are we going to get there? Does this require government standards?
Probably. The government is talking about, has a program of quote, interoperability, where systems are supposed to be able to talk to each other. It doesn't work very well yet. They have another program of meaningful use. I've heard a lot of my colleagues call it meaningless use. But both the software and the hardware and the healthcare providers using them have some changes they need to make in order to be able to make this work a little bit better. There are also some security concerns, some privacy concerns, and a number of other things that have to be worked through. We're not quite there yet.
Is this use of technology that's now a basic element of a medical education? Are the kids all learning this?
Yes, to some extent. They're usually much better with it than the faculty who's trying to teach them. But our graduates all come out knowing a fair amount about using electronic health records. There are some very cool point-of-care devices in terms of doing things like tracking your caloric expenditure each day and what your caloric intake is each day. Some things that do a very good job of tracking your blood sugar. There are some very interesting tools coming that I think will make lives easier for our patients and will allow us to help them have better health care.
Devin, are you seeing that with your diabetic patients? Are there technological changes they can use to track things?
For some of them that are early adopters of technology, bring in their USB card and plug into the computer and show me their graphs. I've had a couple of patients that can sort of send them to me electronically, but I would say not the majority.
Well, I guess if a patient is afraid to get a shot, she might be afraid to use.
Oh, she's got a smartphone. She's very, very good at the smartphone.
Yeah. Dr. Stream mentioned that other countries, even though we're the world's richest country, have better health outcomes and cover everybody. And I personally feel these electronic medical records is another area where they're better than we. In France, there are 62 million Frenchmen, and everybody over the age of 6 has a green card. It's called the Carte Vitale, and it has her whole medical record on that. And any provider, any doctor, any PA, any pharmacist can get a reader and read it and know everything, and it's all interchangeable. Germany is doing the same thing. Theirs is called the Gesundheitskarte. And Taiwan has the e-cart. Everybody is on the same system, and it's so frustrating to come home to America and see what are there 220 different vendors, and they're each proprietary. It would be nice to see this. How long is it going to take, Glenn, before we have a standard system?
Well, Tom made an important comment about the privacy and security aspects, and what those countries have that we don't is what's called a unique patient identifier, something that identifies that person uniquely. So when you plug in that card, you have to know that it's this Glenn Stream. There actually are 2 other Glenn Streams.
Okay.
You think you have a unique name when you're listening.
Yeah.
But there are 2, and you have to know who's who. And so the system has to be able to identify that person. Legislation was passed that enabled that nationally, but it was never funded because of privacy concerns.
Richard, are technological advances getting into the health centers, community health centers?
Sure they are. This is interesting conversation because you really need to be informed about history to consider this whole thing. And fortunately, Tom gave credit to the Veterans Administration and the military, lest we forget that this all started with the Indian Health Service. These were government-sponsored technology programs that were on the way, even early years, on the way to excellence. Enter private industry that lobbied for their product, and then we got sidetracked. But that said, I really think this is one of those things, the wheels of change grind slowly, they grind exceedingly small. We will find an answer. One of the coolest things is I'm recognizing who's in the audience here, the younger folks coming up through the ranks, that this is their problem. They're going to solve it. They'll solve it. Technology is going to solve it. They're not intimidated by it. They don't. You hear the bitterness come through, but I don't see that at all in the students and the residents that I train. They'll solve it. I think we're close, and we will absolutely get there. I do think that it's important to remember it wasn't that many years ago, before we did that of my 1,200 diabetics in the practice, I thought I was pretty good when they came in, and I thought I knew what to do with them, medically speaking. But the support tool that came about with the electronic health records, that now at a push of a button, all of my providers have their list of the diabetics that they care for, and sure, you can talk about which health measures were given to those, the health services that were delivered to those people when they came in. But most importantly, I know exactly who didn't come in, when the last time they came in, and how to get a hold of them, and and so I can go get them. So that's a huge paradigm shift that we should give credit where credit's due. To make these things work for the health of our communities is there. I believe it's around the corner, and yes, we're going to need government to step in with a very strong hand to make it happen.
Devin, in your group treatment, do the millennial patients teach the older people how to use technology, or make them feel comfortable?
Probably. Although the groups that we get together are generally matched by at least decade, so they're fairly similarly matched. Patients over 65 and retired, we try to get those together because they have similar experiences during the day, not particularly tech savvy. And then we get some younger patients, put them together, and they have their smartphones, and the conversations that come out are different. But I've found that taking patients from different generations and putting them together has been a little bit less effective at helping patients with self-management than getting them together where I can at least guesstimate that their daily experiences are relatively similar.
Oh, interesting. Yeah. Glenn?
I was going to say it's one of the unique things in family medicine is it's usually family members teaching each other the technology, and you really can elevate the prestige of the 11-year-old by empowering them to teach
Sure.
their parent how to use their smartphone.
Yeah, that's right. Yeah.
Well, along the same line, Devin was saying that we're not quite there yet with his diabetics being able to take their home blood sugar and get it into his electronic health record. A piece of technology that's been around for a while is the home blood sugar, which started in 1978. And we have made great strides because of that technology. So technology really does help us, but it takes a while to learn to use it correctly.
If I could jump in a little bit on the technology picture. I think there's two things to distinguish here. There's sort of hardware, software. There's the sort of physical technological changes that are happening, and then there's the era of information. And I think most of what we're talking about in a lot of ways is technology that has enabled us to increase the access to usable information. And it's frustrating because there's not, there aren't common standards to share that information, but there's very, very rapid access to more information than ever. And it's democratized. So I often ask myself, this is great. We know primary care is really valuable right now, but medicine itself and technology, and medicine largely due to technology, is advancing incredibly rapidly. And our understanding of disease and, really the fundamentals of disease, like, what is even depression? Like, do we even understand what that is? I don't think we do. I think we're starting to see some glimmers of what's going on in the brain that explain that depression is probably a wide variety of different disorders caused by very different things and that do very different things to the brain but have a common symptom, like back over 100 years ago when fever was a disease, until we realized that, I guess it was longer than that, then we realized, and there are still remnants of that, like typhoid fever, this fever, that fever. It was considered a disease, and then we found out it was a symptom. I see that on the horizon, and I see that as being possible because of technology and information, computation, and all that kind of thing, and the intelligence that we can get out of all this information now. So I think a lot about what's my role going to be 10 years from now, and I look at all of you up and coming physicians who are going to be dealing with this. And luckily, you're comfortable with technology, but I think we all have to challenge ourselves to say, when these paradigm shifts, like you're talking about, Rich, when they come, they're going to hit us really hard. And we have to think hard about the role of the generalist in the future of healthcare. I firmly believe that we will be incredibly important, probably more than ever, to help people translate what's going on. And it's going to be a different kind of experience. And I think it's going to elevate us to a totally different level of work. And it's no longer going to be about following protocols and doing this and doing that. It's going to be about gathering and analyzing a lot of data and coupling that with the human experience and knowing that individual and coming up with an individualized plan of care that makes sense for that person and that makes sense for our society. That's exciting to me. And I think that we're stumbling along right now and it's all very choppy and we're trying to figure out how to do all this kind of thing. But I think we have to put ourselves into the future and think what's going to be relevant and how am I going to use technology and information to enable me to ride that wave and get ahead of things so that I can continue to help my patients and be relevant to their health.